All right, so the lecture will be recorded, and I'll share this with you a little bit later on through a YouTube link. So here's what we're going to do. We're going to move on to AV arrhythmias for today. We're not going to get through all of the AV arrhythmias. On Wednesday, my dean has requested me to meet with the president of the Kentucky Senate legislature. They're looking at a potential project to involve EMS in Kentucky. So he wants me at that meeting. So Professor Pfeiffer will be in here. And what I will have Professor Pfeiffer do is I will build it, and it'll only be a review over rhythms, sinus, atrial, and whatever we cover today. Okay. When you come back, you will have another quiz on Wednesday that will only be sinus or atrial. It will not be anything that we cover today. So it'll be the same content, not the same rhythms, but the same content as what you took for your quiz today. Is everybody clear on that? All right. So because we're recording, Matt, you have a question?
Yeah, I was just going to ask, what was the date for the course now?
It is, I think it's the last Thursday, Friday of April. I will have to look. I'll send that out to you. Normally, they give a student discount, so please don't, if you go to their webpage, don't sign up for it yet. Let me save you some dollars. And I'll get you the whatever the code is if they offer a student discount. But I believe it's the last Thursday, Friday of April. Yes.
It says on their Facebook, April 11th and 12th.
Okay, it's not the last. It must be up towards the top. Okay, I'll get you the link and finalize for sure on the dates. All my dates are starting to run together now. So, but again, they for the last 2 years they've always had a student discount, and so I want to save you some money. Okay, that would be what, a Tuesday. Yeah. All right, so we started out with rhythms in the SA note. Then we moved over to the atria. Now we are going to move into, if my little clicker will work for me, into the AV node. Now, again, remind me, what is the purpose under normal operating procedures? What is the purpose for the AV node? And why is that important, Matt? Yeah, very good. Very good. So it stops the impulse for a fraction of a second so that the atria and the ventricles don't contract at the same time. Now, there are several different types of rhythms that you're going to learn about that come up from the AV node or the AV junction. Either one of those are perfectly acceptable to use. They are interchangeable. As a matter of fact, we're going to talk about, probably not today, but we're going to talk about junctional rhythms, junctional bradycardia, junctional rhythm, and a junctional tachycardia that arise from the AV node. You could call them nodal bradycardia, nodal rhythm, or nodal tachycardia, but that's not the correct nomenclature. If you say that in the presence of your other EMS and healthcare colleagues, they're probably not going to know what you talk about. So we're going to call them junctional. Now, here's the thing. There are a number of reasons why we might get this delay. And in particular, we're probably going to be able to cover 4 of these rhythms today. And basically what it does is it holds up the impulse and then eventually it sends it on down. Or, again, like I like to say, your patients have not read your textbook. It will hold up the impulse and not send it down at all. Okay? Which can run into some life-threatening problems for your patients. Okay? So these four, and I like teaching about these four because they are really, really very interesting to me, and they run the gamut from all the way over here, going, no big deal. If we did EKGs on everybody in here, at least one of you would have this type of rhythm called first degree block. Okay, it's a normal rhythm in kids because their conduction system has not yet fully developed, and so we see first degree block and we go, no big deal. All the way over here to third degree block, and we go, uh-oh, this is almost always going to be a life-threatening problem. We're not going to talk about how to treat these particular rhythms until we get a little bit deeper into the semester after the spring break. So identification is going to be critical. So what causes this block? What causes this mix-up, this hold-up at the AV node? Well, number one, we can see is that the node itself can be damaged by disease. And that's the most common reason, is that patients have heart disease, they have decreased blood flow to the AV node, and as a result, cells begin to die. Now, this is a critical thing that I want you to remember. When heart cells die, they don't do what? Two things. Well, they won't reproduce. You're exactly right. So when heart cells die, they scar over and they're gone, much like brain cells. Matt? They do not conduct electricity. This is one of the reasons for that blockage, okay? So the impulse in 3 of these 4 rhythms that we'll talk about now does eventually get through. But dead heart cells do not conduct electricity. What's the second thing that dead heart cells do not do? You're close. Yeah, they're dead. They're dead. But they do not contract. Okay? So, again, this is a new concept I want you to put right here in the very front of your brain because it is critical to identifying emergency cardiac patients. Number one, dead heart cells do not conduct electricity. The electricity, literally, if this is a bunch of dead heart, this is your normal pathway. And all of a sudden you have a bunch of dead heart cells right there in the middle of it. It has to do this. And we will see that in advanced cardiology. You'll be able to pick that up on your 12 lead. You'll be able to actually see, oh, I've got some conduction problems there, probably from dead tissue. So it does not conduct electricity, and it does not contract. If we get a bunch of cells in the heart that don't contract, what happens to our patient? Why? You're right. Tell me now why you're right. And what's a medical term for that force that we talked about? Starts with an I. Travis? Help him out. Inotropy or entropy. Either one. Inotropy or entropy. Entropy. In, out. In, out. In, out. Except when we have dead heart cells, we have in, out. In, out. So we don't have the entire heart that contracts. This can lead to heart failure. Remember that. Write it on your hands if you have to. Okay? Now, AV blocks are classified according to, it says according to the site or according to the degree of the block. In here, we are going to classify them as according to the degree of the block. Okay, now AV blocks can happen at the AV node, at the bundle of His, or down into the bundle branches. Now, when we get down into the bundle of branches, based off of a simple lead to rhythm strip, which is what we've been doing with, these are all lead to views, okay? One view of 12 different possible views that you'll look at. There's no way on this green earth that you are able to identify whether it is one of the bundle branches. You got to have a 12 lead for that, okay? That's beyond the scope of this class, so don't worry about that until later. However, what we can do is that we can identify one of those 4 rhythms that's going to come into play. Now, first degree block. Let's talk about what that is. Remember, I said first degree block is almost always, remember there's almost never an always or never in medicine, with a few exceptions. But first degree block is almost always a non-life threatening rhythm, okay? Again, if we did an EKG on y'all in here, I would dare say at least 1 or 2 of you would show with a first degree block. If we did an EKG on an infant or a 2-year-old or a 3-year-old or a 4-year-old, I would tell you we would almost always see some form of a first degree block. Why? Because the conduction system of the heart, that all of ours is fully matured. Now, it is not completely matured yet. Okay? So what is a first degree block? Well, basically what happens, I guess I am going to have to stand up here. Let me see if I can find a marker that will not. This is a highlighter. Oh, perfect. So, here is our heart. SA node goes over here, comes down to here to the AV, comes down into this area, and then we get this, okay? Now, we know that under normal circumstances, when the SA node fires, it comes down to the AV node, and we've already talked about the fact that it holds that up for a certain period of time. Now, again, what represents the time frame from the time that the SA node fires to the time that that impulse is released out of the AV node? Hallelujah. And the normal PR interval is 0.12 to 0.20, or 120 milliseconds up to 200 milliseconds. They're both the same measurement. Okay. In a first degree block, for some reason, and most of the time, the reason is idiopathic. Now, what does idiopathic mean? I didn't disparage your intelligence. Travis, what? I love that. What's this mean? I don't know what this means, right? Or Travis? Yeah, that's what it means. I don't know. Okay, we look at it and we go, yep, it's there. Why is it there? I don't know. Don't know. Don't really care. As long as our patient is fine. Again, we look at our patient and assess him or her, not what we see on the cardiac monitor by itself. So basically what happens here is it fires at the SA node, it comes down here to the AV node, and it gets held up. And it gets held up. And it gets held up. It gets held up for longer than 0.2 seconds or 200 milliseconds, and then it gets sent on down into the ventricles. Now, riddle me this, Batman. As it gets sent down into the ventricles under a normal impulse, okay, and it'll follow the same pathway that it would normally follow if there was not a first degree block, would you expect the QRS to be a normal width or to be a wider width in first degree block? Why, Catherine? You're right. Now tell me why you're right.
Because it's just getting held up, like there's no other problem with the rest of the structure.
Good. I love being around smart people. Y'all are awesome. Everybody understand that? It's all it is just getting held up here at the SA node. I mean, it's the AV node. Okay? But then it gets sent on down and it depolarizes in a normal manner. The only difference with a first degree block is that the PR interval is greater than 0.20 and almost always that PR interval will be constant. Now, what do I mean by constant?
The same
Bless you.
time,
Yeah,
complex.
it will be the same. There may be a little bit of variance, but not much. Okay? Now, here's the other thing. What did I tell y'all about PACs last week?
You have to identify the underlying.
Say it again.
You have to identify the underlying.
With PACs, you have to identify the underlying rhythm. First degree block, you do as well. Okay? You do as well. Now, a first degree block will almost never be a tachycardia. Why?
It's slowing because it's being held up, which means it's less cardiac output.
Yeah, so dromotropy, remember dromotropy refers to, what is dromotropy? Inotropy, we've already gotten from Travis, we got in and out.
How fast it travels through the heart.
How fast it travels through the heart. So dromotropy starts up here at the SA node and comes down here until all the cells of the ventricles have been depolarized. So just like James said, if it gets held up here, it is rare, I'm not going to say impossible, but it is rare that you would see a heart rate of greater than 100 with a first degree block. Now, the other thing you got to remember in here, this is why the 5-step process is so very important. I know you think I'm obsessed with that, but I want you all to be successful. So as you're going through that, you look at your P waves and then you look at your PR interval. And now what I'm going to ask you to do is that in that 6-second strip, when you measure your PR interval, you want to measure all of them that's in that 6-second strip. At a certain point, by the end of the semester, you'll be able to look at it and say, I'm not sure exactly what the PR interval is, but I can tell it's normal or it's extended. That PR interval should be pretty much the same as we're moving through. If you want full credit for a PAC, you have to do what? Tell me the underlying rhythm. Ladies and gentlemen, same rule holds true for first degree block. You cannot tell me, oh, it's a first degree block. It's not truly a block because it's letting it go through, but it is superimposed on an underlying rhythm. Okay? Now, as far as the etiology of it, etiology just simply means what causes it. Ischemia could cause it, but most of the time it is what I'm going to call the Travis maneuver. I don't know. And so we don't really worry about it. We look at our patient, we assess our entire patient, though. So here's our 5 steps. Number 1, rate. It depends on your underlying rhythm. Usually it will be less than 100 impulses per minute, though. Okay? Rhythm. The rhythm will normally be regular, except if you get some variances right here as far as how long it gets held up at the AV node, you can get some variances in your R-to-R interval. Now, again, just by way of review, when you're measuring your R-to-R intervals going across, everybody knows what the R-to-R interval is, right? That's the space between this R wave or this R point and this R point, and we compare them going across. As long as they are within 2 small boxes or less, we consider them to be equal. Okay. Anything greater than 2 boxes, then we would call it irregular. All right. Probably in that situation, if it's like 3 boxes off, we call it slightly irregular. All right. Doesn't mean that patient there's something major wrong with our patient. Just shows that you're becoming really, really well versed in EKG identification. So your rhythm is normally going to be regular, could be just a little bit irregular. Your P waves are going to look perfectly normal. Why? Say it again, Sydney. What's not happening at the sinus node? So actually the opposite is true. The impulse is originating, we can say, within the sinus node or within the atria. So a normal looking P wave would tell us that it's coming from a normal spot in the atria somewhere. Okay? So your P waves will look the same. All right? They will be consistent as you're moving across. Your PR interval. Here's your money shot. Okay? Your PR interval is greater than 0.2 seconds or greater than 200 milliseconds consistently in that 6-second strip. That consistently is going to be really important in just a minute, because in just a few minutes we're going to talk about a block in which the PR interval could be normal, it could be less, it could be really wide. But that consistency is important, okay? Therefore, then, our QRS is also going to be narrow for the very reason that Catherine just said. It's starting up here in the atria, and it's following the normal conduction pathway. It's just getting held up at the AV node for a little bit longer than 0.20 seconds. Now, do we need to worry about this? Most of the time, no, not at all, okay? Now, if we have a really slow heart rate, if we have a pronounced bradycardia, and our patient is beginning to get symptomatic, now we have some concerns. We'll touch on the treatment for those a little bit later on, as well as some of the signs and symptoms that you would see in a patient that either has a heart rate that's too slow or a heart rate that's up here too fast. But for the most part, a first-degree block would be, we're not really concerned. So, ladies and gentlemen, what is the underlying rhythm of that EKG? So how, for all the points, all the marbles here, how would you identify this on an exam or a quiz? Perfect. You could also call it a first-degree block with an underlying rhythm of sinus bradycardia. As long as you got both of them in there, and it is indeed a sinus bradycardia, you're golden. You're good. Okay? Now, let me stop. Questions about first-degree block? Yes?
You said it's like common in like children to grow out of it in a sense.
Mm-hmm. Yeah, so as the child develops in utero, still in the mom's uterus, the heart and everything is continuing to develop and to progress. However, as the child is born and now it's getting older, it's getting larger, it's growing up, that heart has to continue to progress and change, both physiologically and structurally. And so as it goes through, the conduction system is not, it's where it needs to be, but it's not where it needs to be as the child gets older and larger. So for example, give you an example. Have you heard of babies that have had to go in and have a surgery because the common term is they got a hole in their heart? Yeah, that's normal. That hole in their heart is completely totally normal while the child is in utero, while it's developing. Shortly after the child is born and they begin breathing and they begin not relying on mom anymore, but their circulatory system for themselves, under normal circumstances, that heart closes up really, really quickly. Another anatomical change that takes place. So the same thing takes place here as the child gets older. The cardiac system continues to grow and expand and becomes more stable to add into what's going on for that child at that particular time. Good question. Anybody else? I'm not going to rush. All right. Identify that rhythm for me, please. What's the rate? What's the rate? Okay. So again, we've got this hash mark. This QRS lies completely outside of that hash mark. Same way over in here. So we would only count 1, 2, 3, 4. Now again, when I give you rhythms on a quiz or on an exam, you're safe unless I specifically tell you different. So for example, like on this one, on number 8, I told you number 8 was a 12-second strip. Okay, I will let you know if it's anything other than a 6-second strip. Okay, so we count only those that are inside there. So we know automatically what? Go ahead. Yeah.
If you give us a 12-second strip, would it be the same rate?
Well, basically, what I would like to think, let me see if I did it on this one. No, I did not. I cut the hash marks off. So basically, what you would do is you would count a couple ways you could do it. You could count the QRS complexes and divide it by 2 and then multiply it by 10 to get your rate. Or you could count the QRS complexes and multiply it, because it's a 12-second strip, and multiply it by 5. And you'll still come up with your rate that way. All right, good question. So we know that this is a bradycardia. Rhythm. Okay, good. Do you see P waves? Do the P waves look pretty much the same going across? Okay, so when we see the P waves that are the same going across, what does that tell us? Say it again? They're coming from the same pacing site. Good. Yeah, so they're coming from the same pacing site. So, does every P wave have a QRS? Yeah, does every QRS have a P wave? This is where that question, or those two questions, are going to become really, really important, because in a minute we're going to see a rhythm that will often have a P wave with no QRS, or we may see a QRS that doesn't have a P wave. All right. What do you notice about your PR interval? Okay, we're talking about first degree blocks, so it should be longer. Okay. Is it constant? Are you sure? Good answer. Okay. Yeah, it is constant. It is the same moving across. What do you notice about the QRS? All right. So identify this rhythm for me. I've already given you half of it. Everybody see why that is sinus bradycardia with a first degree block? Anybody not see that? Do not be bashful, because if you're struggling, I can guarantee you somebody else is. James.
Well, counting QRS, there looks to be 6, unless I'm mistaken.
So I think you stepped out here. Look up here at the hash marks. This QRS is outside of the hash mark, so we don't count that one. Same way on over here on, well, I'm at a bad angle, on the last one. The last QRS is outside that. Now, here's the thing. Let me make sure everybody understands again. If I give you a rhythm strip on a quiz or an exam, it will always be a 6-second strip unless I identify it differently. Not so up here with that. So that's why the rhythm is 40 and not 60. Travis.
I just have a question on the quiz, on the online quiz. At what point is the QRS considered in the strip? Is the entire...
Oh, good question. Okay. If 50% or more of the QRS, not the P wave, not the T wave, but if 50% or more of the QRS is inside. So, for example, let me see if my, no, I don't want to restart my computer. Go away. Laser pointer. So you can see right here is our hash mark. And so we're coming straight down this line here. And as such, almost all of the QRS lies to the left of that. All right. If this QRS were lined up straight on this line that's coming down where the hash mark is, then we would count it because it's half or more of the QRS is within or on that line. So again, you would look at 50% or more of it being on or to the right or left of the line to count it. Does that make sense? Okay. Everybody else, does that make sense? Because I confuse myself sometimes. So does everybody understand that? Okay. Anybody not see why this is sinus bradycardia with a first degree block? Again, you tell me first degree block, I'll give you half point. You tell me you tell me sinus bradycardia, I'll give you half of the points. All right. If you want them all, you got to identify it that way. Rate. This is a 6-second strip. Ooh, so we've changed. Rhythm. Okay. P waves. Do they look consistently similar to each other? Why am I asking you that question? Say it again. Yeah, for MAT and WAP. Now, we know this would not be MAT because it's not what? That's not tachycardia. It's not fast enough. But it could be WAP. Good, Sydney. Very, very good. All right. PR interval. Now, regular goes to rhythm. Is it a normal or is it a widened PR interval? It is widened. By how much? Let's take a look here. So of that first PR interval, what would you estimate it to be? Sounds good. I would say 0.22. You could go as high as 0.24. I'd be okay with 0.22. I'm not going to ask you to get exact because, again, these are small boxes. Is the PR interval constant? Is it constantly 0.22, 0.24 moving across that strip? Yeah, it is. Okay. Tell me about your QRS width. Yeah, it's regular. It's regular. So, ladies and gentlemen, what would this rhythm be? Oh, you make me so proud. Yes, normal sinus rhythm with a first degree block. Okay. If you tell me it's first degree block with a normal sinus rhythm, are you going to get the points? Everybody do this. Yeah, you are. Okay. Because you've identified it correctly. All right. Any questions? Okay. Strap in because it's getting ready to get fun. We have two different types of second degree block. Okay. A second degree block can also be called a Mobitz. Let me back up. A second degree type 1 block can also be called a Mobitz 1 block, or it can be called a Winky block. Remember, doctors have egos. That's named after a Dr. Winkelbach who discovered this. Okay. And basically, what we see in a second degree type 1 is the PR interval gets longer, longer, longer until you have a P wave and no QRS. No QRS. Okay. Your PR interval can already start out greater than 0.20 seconds, or it can start perfectly normal, and then it gets longer and longer and longer, and then all of a sudden you got a P wave, and poof, no QRS. Okay, the QRS is blocked; it does not go through. Now, secondary type 1 is still considered a low grade block, but I am going to tell you, okay? I'm going to tell you that if you've got a patient with a second degree type 1 block, you need to watch your patient closely. Why? Because we don't want them to progress into a second degree type 2 or a third degree block while you're taking care of them without us recognizing and treating it. Generally, what causes this is increased parasympathetic tone. Now, what does it mean to have increased parasympathetic tone?
Like you're too relaxed.
Good. So the parasympathetic nervous system is working overtime and you're too relaxed. You're too relaxed, okay? There are certain drugs, and what those drugs are now, you don't need to worry about them, but certain drugs can cause it, as well as ischemia. Ischemia in the heart means what? Ischemia in the heart means what, Travis?
Blocked cells, well, they're dying cells.
Not dying cells, but struggling cells. Ischemia means, go ahead. That's exactly what it means. Not enough oxygen at the cell. The cells are not dying yet, but if we don't fix it, eventually they will, okay? Put it in real life. Y'all are college students. Everybody's in here wealthy, right? That was a joke. A poor one. If you get your salary cut, you're going to struggle. You're going to feel pain. You're not going to be able to function like you normally would. If you lose your salary altogether, you may have to do what? Declare bankruptcy. Okay? That's devastating. That's not good, regardless of what you see on the commercials. This is similar. Cells that are ischemic don't have enough oxygen. They have some, they don't have enough. They're still functioning, they're not running at top capacity. Cells that die or infarcted are bankrupt cells. They die. They're not coming back. Okay? They no longer function. So our cells are still working here, they're just not working as well. Okay? So what is our 5-step here? First of all, we look at the rate. Generally, what you will see here is that your atrial rate and your ventricular rate will be different. Why?
Held up at the 80
What's getting held up?
or
And it's resulting in what?
longer pods.
True. But why would your ventricular rate, as shown by your QRS, be less than your atrial rate, as shown by your P wave? Yeah, this will become clear here in just a second. Okay. So we look at our rate. And again, when you look at this, I will tell you right up front, you will get to the point of where you'll go, that's a block. Not entirely sure what block it is just as of yet. Let me investigate further. I'm going to give you a little tool that helped me back in the dark ages when I was learning these things that really, really helped me to differentiate between these four blocks. So, as we're looking at this, now we want to look at the rhythm. When we look at this, your atrial rhythm is usually going to be regular. That means if you measure from your P wave to your P wave to your P wave, it's going to be the same distance across your 6-second strip. Your ventricular rhythm will be irregular. Why? Why? What's not? Bingo. So you drop a QRS, and when you drop a QRS, that automatically makes it irregular. Okay. Now again, when we see an irregular rhythm, what's our next question? Is there a pattern? Is there a pattern? Okay. Can't really tell with 6 seconds. All right. We'll give you longer strips a little bit later on. Your P waves. Your P waves in second degree type 1 block will look normal, and they will look the same because they're coming from the same impulse. In this rhythm, does every QRS have a P wave? Are you sure? I'm not trying to change your mind. I'm challenging you. You're sure?
Yes.
Okay. I agree with you. Every QRS has a P wave. Does every P wave have a QRS? See, y'all thought I was just crazy. You thought I was an old crazy man back at the beginning when I kept asking you, does every P wave have a QRS? Does every QRS have a P wave? See, I told you that there would be a method to my madness. No. We see right here. Here is a P wave. Where is its QRS? It doesn't exist. It does not exist. That's the essence of an AV block. Okay? Now, here is how you tell the difference, or here's how you identify a type 1 block. Let me do this. What would you say about that? Well, you're not seeing my cursor. What would you say about that PR interval?
Can you point to it again?
Say it again.
Can you point to it again?
Absolutely. Absolutely. Let me get
The first one?
the very first one right here. What would you say about that PR interval? Yeah, it looks normal. Does everybody see that it looks normal? Okay, stay with me. Compare it to this PR interval. What difference do you see? So it's first PR interval, boom. Second PR interval, it's getting held up there just a little bit longer. Hey, look over here. What do you notice about that PR interval? It's wider. But wait, there's more. We come over to our next one, and we got a P wave. And look at that. What is this? Let me zoom back out. So is this P wave attached to that QRS? Yes, it is. Go ahead.
The pause gets so long that eventually just doesn't do anything.
Yeah. So the pause gets so long that eventually we get an impulse, as shown by that right there. That's your P wave. Remember, here's our T wave. How do we know this is a P wave? Well, we compare it back here to our other P waves, and it looks similar. and the AV node just holds on to it and says, nope, not going through. And if there's not an impulse that goes through, at least in this rhythm, your ventricles do nothing. What is the danger with this particular rhythm? Not necessarily. Now, we'll talk about a condition that exists where that can happen. It's called regurgitation. So literally the blood can be pushed back up in to the atria from the ventricles. That's usually from a faulty set of valves between the atria and the ventricles. But what is the danger here, James?
Well, if it's not going through to the ventricles, doesn't it just sit there, or does it backflow?
Doesn't backflow. Now that's what she was saying. That's regurgitation. Where is it? Where is the blood not going? And then where is it not going? Or the lungs. So it's not going to the body or the lungs. That means our cardiac output drops. Okay? Our cardiac output drops. All right? Now, your QRS can be normal or it can be widened. Now we're getting into, because what may happen is the ventricles may recognize the fact that the atria is not doing its job, or they're thinking it's not doing its job, when in fact it's the AV node that's holding up the impulse. Remember, if the SA node fails to fire, what is its backup? And if the atria fails to fire, what is its backup? And if the AV node fails to fire, what is its backup? The Purkinje fibers or the ventricles. So it is possible that you could see an ectopic in here, an FLB. Okay, when you're talking and doing your exam, don't use FLB. That's just kind of a bill term. But you can see an ectopic in here because the ventricles may say, dude, we got to do something. If we don't do something, Bill's going to fall over and he's going to pass out. And we'll get a wide, bizarre-looking QRS. But usually not. Usually not. Okay? So the big clinical significance that we see here is that the heart rate drops even more so than what we would see in a first-degree block. Cardiac output can drop. It can result in chest pain known as angina. Okay, it can come about in an altered mental status. Your patient may pass out, called syncope, or they may say, oh man, I feel like I got to sit down. I feel like I'm going to pass out, which is known as near syncope. Near syncope. The thing that we're looking at here is this is an early warning system. Remember, with first degree block, we said, we don't really care. Okay, as long as our patient's stable, we're okay. Even if our patient is stable and they're presenting with this, we want to watch our patient. Okay, we'll talk more about what watching your patient means at the end of the semester. Okay, now don't worry about treatment going in here. Let's do a little bit of practice. What is your rate? Watch your hash marks. Say it again. 50. Everybody say it's 50. Sydney, you look confused. Okay, good. Rhythm. It is irregular. Okay. P waves. Do you see P waves? Do they look like normal P waves? Does every QRS have a P wave? Yeah, every QRS has a P wave. Let's look. QRS, P wave. QRS, P wave. QRSP, 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 QRSP. So yeah, every QRS has a P wave. Does every P wave have a QRS? No. P wave? Nothing. P wave? Nothing. Okay. Now, Next thing we want to do is let's look at our PR intervals. What do you notice about the first PR interval here? How does it compare to this one? What happens here? This is where you would have what is called a 2-to-1 block. You have 2 P waves and QRS complexes, and then you have a block. You have no QRS. What did we have? Let's go back to the previous one. How would you identify that as a ratio of blocks? 1, 2, 3, 4 to 1. Yeah, that would be a 4-to-1 block. Now, if you want some extra bonus points, until I tell you otherwise, on your quizzes, on your exams, if you correctly identify that this is a 2-to-1, 3-to-1, 4-to-1, or whatever block, I'll give you 50% bonus for that particular question point. Okay? All right. So, go ahead. Good question. Okay? Nope, don't apologize. Here's 1. Here's 2. Here's 3. Here's 4. And then we have a P wave and nothing.
Oh, okay. I was counting that other for the third QRS.
Okay, I'm glad you asked. Okay, so in essence, what we're doing here is, let me just do it this way. Okay, so this is 1, this is 2, this is 3, this is 4, and this one has nothing. So that's our dropped. Okay, so we have 4 conducted P waves to 1 dropped P wave. Does that help?
Yes. Would there, so say there was those 5 QRS sequences, and then there was like, after the second QRS, there was a P wave, and then a dropped QRS, and then it picked up the 3 QRSs, and then another dropped QRS. Would that be like a 2-to-1 and then a 3-to-1?
You could call it that, but normally what we would call it a variable conduction. So yes, you are exactly right. You could call it, okay, on the 6-second strip, there's a 2-to-1 and there's a 3-to-1. I'd be perfectly okay with that if it's indeed that, or you could just simply say it's variable. Very good. Very good. All right. Everybody see why that is what's the ratio for that one? 2-to-1. Everybody see why that's a 2-to-1 second degree type 1 or a type 1 second degree. You can't just call it a type 1. You can't just call it a second degree. You can call it a Mobitz 1 or you can call it a Winky-Bach. I don't care. Okay? Rate. Okay. Rhythm. Okay. Do you see P waves? Does every QRS have a P wave? Yeah. Does every P wave have a QRS? Now, does everybody see that not all P waves have a QRS? If you do not, please, please, please let me know. Raise your hand. Okay. What do you notice about the PR interval? Yeah, it starts out here, and then it gets wider here, and then it gets wider here, and then it gets wider here, and then bam, we have a drop. What do you notice about your QRS? It's hard to tell if it's wide or not. Let's blow it up and let's take a look. So I would say it starts 1, 2, 3. So I would argue that your QRS is 0.12 seconds in width. It's not any wider than that though, but it's close. So it's still going to be normal. It looks wide because we've looked at a bunch of them that have been basically 0.04 seconds. All right. Now, secondary type 1 does not have an underlying rhythm. It is a standalone rhythm all to itself. So you do not have to tell me an underlying rhythm. As a matter of fact, if you identify an underlying rhythm, I'll count it as wrong. But this is second degree type 2. What is your ratio as far as the blocks go?
4 to 1.
Why 4 to 1?
There's 4 QRSs or complexes before the beat or drum beat.
Okay. Everybody see why that is 4 to 1? Yes, Matt.
Can the PR intervals get like wide enough that the P wet is hidden in the T wet?
Yeah, sure can. How would we know when that happens?
It would be a larger T wet.
Yes, sir. You are correct. You are correct.
Is there a ratio when you say conduction?
Yeah, I'll be okay with that. Yeah. So if you tell me it's like a 4 to 1 conduction, yeah, I'm okay with that. Staying the same thing. Yeah. Other questions? Let's do another one. Rate. This is a 6-second strip.
40.
Rhythm.
Irregular.
P waves. PR interval. Good. So it starts out here, okay, and then it widens, and then bam, we drop one, and then it starts again here. Now, we're really not able to determine the conduction or the ratio of conducted beats to drop beats from this rhythm strip because it's so slow. Why did I say that? Because when the pattern starts over again, it generally will almost always repeat itself. Remember, we're picking up, and you look at this PR interval here, and this PR interval is much more narrow than this one right here. So I suspect that there is a P wave with a QRS somewhere over in here that would mimic this one. What we would need to do is run a longer strip or look at it on our monitor. Okay. So this would be a second degree type 1 block. I'm going to stop there because we got about 15 minutes and I don't want to get deeper into the blocks because I'm not in any hurry to rush. But I want to find out questions that you have. We've got 15 minutes, so we're not going to rush to get out of here. Let me come back here and then I'll come down here to you, Matt.
So you can have like an AV block that doesn't have a ratio, but you can also have it that does have a ratio. Like they don't always have a ratio.
You are correct on all accounts. So yes, we will talk about second degree type 2 and third degree block because remember on Wednesday Professor Pfeiffer will be in here with you and all he's going to do is to review up to this particular point. But yes, when we get into second degree type 2, we can have a block where it's all over the place. There's no rhyme or reason. That's an excellent question. Matt.
So, for like testing for quiz purposes, if you have like this rhythm, we would be able to, I would say, like, that we can like, I guess that's a 3-1.
What I don't want you to do is don't want you to guess. So we don't have enough information here. Now, if you were to tell me not enough information, then yeah, I'd give you the bonus points, because literally we're just making, based on what we've got in here, we're just making an assumption that we've got a P wave and a QRS over here, and we're making an assumption that this right here is probably going to be the same width as this one. So it's potentially going to be 3-1, but we don't have enough information to make that determination off this 6-second strip. Anybody else? When you come back on Wednesday, another quiz. Sinus and atrial rhythms. Professor Pfeiffer will cover. We will not break any new ground here, but he will cover sinus, atrial, first-degree block, and second-degree type 1 block. Good class today, guys. Good. Go get you some lunch.